Hello, thank you for joining me. My name is Dr. Anna Bollinger. I am here in Minnesota, sharing about some work I've been doing on pediatric boarding and employee experience. It's June 2026, and I'm starting today's recording from Minneapolis, Minnesota. So to start, patient boarding is the practice of holding admitted or observation status patients in the emergency room for hours or days because there are no inpatient beds available or because an inpatient admission is not appropriate, but the child is not able to go home. I say child, a lot of this work focused on children that were boarding. I did talk with folks that worked with adult boarding as well. My current employer is Children's Minnesota, and that organization uses the term patients awaiting community placement. So you'll see both terms throughout today's presentation. So a little bit more about the scope of the problem. In 2025, about 1,200 patients boarded at Children's Minnesota while waiting for psychiatric and long-term care beds, with over 70 hours of wait time typical. That same year, Ramsey County averaged 5 to 6 months for in-home assessments, which violated state laws that require a 20-day turnaround. This is a problem not just in Minnesota, but nationally and internationally as well. More than half of emergency medicine providers report workplace violence secondary to boarding. Healthcare workers experience non-fatal violence at work at 4 times the rate of law enforcement officers. And boarding is only likely to worsen in upcoming years. Like I mentioned at the beginning, I'm calling in for today's presentation from Minnesota. It's June 2026. As of today, we have news that one of the only locked residential treatment programs in Minnesota is shuttering this summer. Availability for psychiatric rehabilitative treatment facilities, or PRTFs, has gotten more narrow. And providing outpatient services at scale has only become more difficult and difficult to maintain across the state. And so resources are really becoming leaner. And as resources become leaner, people delay care, they wait, or they need to prioritize other things. And so by the time they make it to the emergency room, they're much sicker than they would be had other resources been more available. All the images in today's presentation were generated using Google Nano Banana, which is an AI image generation tool. This is not an actual patient, but it's a picture of what one of these patients might look like. They're more often to be boys than girls. They're more likely to be younger than older. They're also more likely to be people of color. These patients are medically stable, but psychiatrically or behaviorally unstable, and they're waiting alone. This is an infographic provided from Children's Minnesota about their work with decreasing patients, the frequency and severity of the experience around patients who await community placement or pediatric boarding. A large, significant goal for Children's Minnesota is really to increase availability and quality of outpatient services so that kids don't go to the emergency room. It's an admirable and really important goal. Some kids do go to the emergency room and are not appropriate for an inpatient admission because of the significance of the behaviors or how ineffective other resources have been that could offer help. Caregivers don't feel safe bringing that child home, and that child then becomes somebody who's awaiting community placement. I think about this problem like an iceberg problem. With mental health, we think about an iceberg metaphor a lot, that whatever we see on the surface of the water is just a small component of what's underneath. All of the problems and systemic failures that bring us as a society to a position where we have a 10-year-old child waiting alone in an emergency room. There's a lot under the water there, and a lot of things that contribute to that tip of the iceberg problem, this child that's waiting for discharge without an available or safe discharge plan. I believe that's the same with adults. Adults that are in the emergency room and waiting, or on med-surg units and waiting to discharge, and they're not able to leave are not there because of individual moral or individual characterological failings. They're there because of these additional failings in broadened and informing what's happening to them now. And so to understand more about this experience, I've been completing interviews this spring and summer with people to understand more about that experience and to really define the problem. So whenever you're thinking about interviews, it's important to know who did those interviews. So I'm Dr. Anna Bollinger. Like I said, I'm a PhD. I'm not a physician. I'm a licensed marriage and family therapist, which is a mental health license here in Minnesota. I'm a white, middle-aged, cisgender woman. I've spent the past 20 years working in high acuity mental health. And I'm a mid-level manager in the hospital system that the majority of these interviews were conducted. So far, I've completed interviews with a number of systems across Minnesota with a variety of different roles. I'm up to 22 interviews right now, and general demographics are listed here. Roles that are represented in the overall interview pool are on the slide deck. You see the majority of folks that were interviewed have been physicians. The second biggest group have been nurse managers and social workers. And I've also interviewed chiefs, business administration, county social work management, referral partners. I'm trying to talk to as many people as I can to really understand this problem. Across interviews, some themes have shown up. I'm going to list them here. So isolation and pressure have really been thematic in these interviews. One interesting thing that's shown up in the interviews has been this tension between some people saying, well, people have the belief this isn't my problem, or frustration with this really should not be our problem, versus people saying things are getting better. I hear fewer people say those aren't our patients nowadays. The last really important theme that I want to call out is that this iceberg problem presents an incredible threat to provider self-concept. Whether hasn't really mattered if you're a physician, a nurse, a social worker, a business administrator, if you're at the chief level, people say, I went into this work to help. And this is a situation that really throws into sharp contrast that there's not a whole lot any one individual person can do right now in this moment to change the outcome. Now, that said, I do believe that together we can help. But that experience is really painful. And a lot of people are saying that I went into this work to help and I feel so helpless in this situation. So the next few slides here are a selection of point of views and how might we. So how might we offer help? How might we offer assistance? How might we solve the actual problem as opposed to presenting a solution that doesn't get at the thing that really matters? And again, all of these images and descriptions are consolidated from interviews. Images come from that Nano Banana tool, Nano Banana with the Google AI, but are meant to help with understanding the problem. Just going to quick hop to my Google and be sure they know that we're still here. Okay, and so here we are, and we'll continue. Louise is a 36-year-old nurse manager in a pediatric hospital system. She leads a team of 100 nurses on a medical surgical unit that also receives medically stable but behaviorally aggressive and dysregulated patients who are boarding in the hospital until a safe discharge plan can be made and they can discharge to community care. Louise needs a way to quickly train union nurses in managing these cases because the relational aspects of this care are not part of nurse training. And without that training, staff don't maintain safe boundaries and frequency and severity of injuries increase. How might we train staff in relational impact of trauma and boundaries in a brief period of time? This could really help Louise. For Louise, how might we make the most effective and efficient use of resources to train, support, and contain staff who are engaged in this work? For Louise, how might we identify key aspects for training relational limit setting and connection for nurse colleagues? And how might we continue to build on the strengths of the nursing team and recognizing that these are our patients? Next up, we have Joshua, who's a 49-year-old emergency room social work manager. Joshua is a 49-year-old emergency department social worker who manages a team of 70 master's level social workers. His team coordinates and maintains contact with county and state resources as needed when a patient does not discharge to their guardian's care and the county has not yet found a placement for them. Joshua needs a low effort but high impact tool to keep these patients top of mind for community partners. So for Joshua, how might we partner with the county to keep patients who are waiting community placement top of mind? How might we lower the impact of daily high conflict phone calls to decrease staff stress? And how might we ensure clear and effective information sharing so that the burden of multiple phone calls a day can be shared across the team? Next up, we have Lane, a 42-year-old emergency room social worker. Lane is 42 years old and one of the 70 emergency room social workers that Joshua manages. She's worked in mental health for her whole career and sees her work in pediatric emergency behavioral health as adult prevention. More than that, she says that kids are easier to change than adults, so the work generally feels more hopeful. She's close to the daily work. One of her biggest stressors is frustration with county teams that seem unresponsive to patients boarding in the hospital, alongside frustration with nursing or security colleagues that sometimes behave disrespectfully towards those same patients, alongside community partners who can always say no. Lane needs a way to see all partners build capacity for caring for complex youth. Without that, she'll be tasked with self-care on a sinking ship. So for Lane, how might we keep her updated about organizational and systemic changes towards good? How can we help Lane find meaning, resilience, and community in the midst of this very difficult work? And how might we help Lane be less alone? Next up, we have Rick, a 33-year-old security supervisor. Rick is a 33-year-old security supervisor who works afternoons and overnights at the same hospital that Lane, Joshua, and Lane work in. He leads a team of 15 officers, and his team is frequently called to put on holds or restraints when patients are dysregulated. On the whole, he likes his work and finds it meaningful, but he does get frustrated and heartbroken about the impossible situations that kids find themselves in, and that they keep finding themselves in those positions. He knows that kids who act out don't do it because they want to hurt you. They're scared and their defenses are up. It's not about you. One challenge he has is maintaining strong culture with his team to support kids with these needs. Rick needs institutional support to keep officers who can get with the program, and if they can't, to get them out. So for Rick, how might we build organizational capacity towards strong culture from the first phone call? How might we support leaders to effectively limit sets so that culture can be maintained? And how might we build policies that protect the organization, drive the mission, and provide good scaffolding for Rick to lean to in limit setting? Next up, we have Aster, who's a 52-year-old hospitalist leader. Aster is a 52-year-old hospitalist leader. She works 7 on, 7 off, and is the organizational leader for 25 other hospitalists and 5 other medical directors who lead a combined team of about 150 physicians. She went into medicine to heal the sick and became a pediatrician because kids have both incredible vulnerability and endless potential. Working directly with patients awaiting community placement seems to only highlight the incredible vulnerability of kids and how broken so many systems are that these kids land in the hospital. One big frustration she has is that when she asks for help from her peers, it feels like she's only told what her team is doing wrong and isn't offered anything to support. When she asks for help from her leaders, she's told in no uncertain terms that those are not our problem. Those kids are not our problem. She sees them as our patients, not as someone else's problem, and feels unbelievably alone in this experience. While all of that is happening, her team is looking to her for leadership guidance and direction. She can offer emotional support, but can't give good advice about what to do, which is the real coin of the realm in medicine. How can we help Aster have meaningfully connected guidance and advice to support all patients in her hospital? How might we help Aster join together with other physician peers to better advocate for changes in perspectives she needs to feel more equipped and supported in this essential work? How might we help change systems so that Aster experiences less moral injury in her day-to-day work with patients awaiting community placement? And how might we help Aster have good guidance to support her team in caring for these patients safely, well, and with excellence? So across all these interviews, again, that experience of being pressured and alone was endemic. As I was talking with people and continue to talk with people, this picture of Atlas, or metaphor of Atlas, comes to my mind, that each individual person feels like the world is entirely and specifically on their shoulders in these moments. Part of what I did was I worked through some AI prompts to develop a picture of this experience. It was really interesting because initially the prompter gave me these really kind of burly, masculine, manly men holding the world on their shoulders, tough. As I asked the image generator to give me images that highlighted how sad and grief filled this experience was, those prompts became emaciated and skeletal. It was really difficult for these images to hold both strength and sadness, and the intense and specific pressure was missing too. So I went old school and I asked one of our nurse colleagues in the program, who was actually an art major before he went into nursing, to draw a picture of what I was describing, and this is what he gave me. Every person I talked to described a sense of the world on their shoulders. Alongside that, every person I talked to described feeling incredibly isolated. In high acuity care, there is a part of this that is unavoidably isolating. It's very, very weird, hard, sad, scary, sometimes incredibly joyful, rewarding work. It's really strange, and it's hard to talk to people who don't know it about it. I know that, and I've been in this work for 20 years. It's strange, and in a lot of ways, it is really isolating. At the same time, the stakes are really high. We're working with people in the worst moments of their life. And for patients who board, these worst moments of their life have become worst moments, worst minutes, worst hours, worst days, worst weeks, worst months, worst years. The idea of making a change with that kind of length of challenge is really hard. And we have to try. The stakes are really high and the work is really painful. And finding sustainability in this work of multiple lifetimes can be a career-long challenge. There are lots of missing perspectives in the folks that I've interviewed. I haven't talked with anybody in union leadership. My flow of bedside nursing has been really pretty minimal. County case managers, the folks that are directly receiving these calls. But really importantly, patient family experience is missing from my interview pool. So if, as you're watching this, you have a child that you got a call and they said, hey, he's got a discharge, come pick him up, and you couldn't, I really want to hear from you. If you're a person who has been in the emergency room waiting to get picked up, if you're a kid, please talk to your parent before you reach out to me. If you're an adult, I would really, really love to talk with you to understand your experience. And also, just about every person I interviewed was white. I'm white. That impacts what comes out in interviews. And so if I had more perspectives, I'm really curious about what they might say, add, clarify, or sharpen with this experience. So all that said, 22 interviews in, what do I think comes next? I think we really need to lighten the load for caregivers that are doing this incredibly hard, incredibly heart-filled, and incredibly intellectually complicated work. So you can change the process, you can change the conditions, you can change the experience, but if you change even just one of those three, you do change some of that outcome. And so what I would propose is a training partnership. We know that employees, teams, and organizations that have an empathetic, accurate, and strengths-based way to think about patients who board are more able to support them more effectively. In providing more effective support, both patient and employee experience will improve. And really importantly, for the buyers in hospital systems, patients who board will be able to discharge more quickly if they are behaviorally stable while boarding. And so thank you very much. Again, I really want to hear your story. So if you have first or secondhand experience with waiting in a hospital to discharge or supporting people in those positions, please reach out. I'm moving to Mosaic Integrative Health and will be their clinical director of mental health. We also really want to help. If you want to find out better ways for your staff, teams, or communities to support people in these impossible, difficult situations, please reach out. Thank you very much, and I appreciate your time today.